Hello. Welcome to IMG's live webinar titled Coronavirus COVID-19 Analysis and Readiness. We understand that this is an extremely stressful and uncertain time for many listening and greatly appreciate you taking the time to join us. This webinar is being recorded and will be available for viewing on demand after the session. Today, IMG Chief Medical Officer Dr. Geoff Tothill will cover several topics on COVID-19, including recent news and developments around the world, how to protect yourself and your organization, and what IMG is doing to prepare in order to continue to be there for our members. After the briefing, Dr. Tothill will host a live Q&A session. Thank you for those of you who submitted questions during registration. At any point during today's webinar, you may submit additional questions through the Q&A feature on the platform. We will answer as many questions today as time permits, and we'll follow up on any unanswered questions afterwards by email. Before we begin, we do want to make everyone aware that this session will be focused on medical and operational topics related to COVID-19. We will not be addressing any specific benefit or policy coverage questions in this forum today. At this time, I welcome Dr. Tothill to begin his presentation. Dr. Tothill?
Thank you, Alison, and welcome everybody from wherever you're joining us in the world. Clearly, COVID-19 is in the forefront of everybody's minds and widely in the media. It's changing the way we live around the world, and I thought it would be helpful in the next 20-40 minutes to talk to you about COVID-19 in some detail, and focus on the current situation around the world and really try and answer some of the questions that we're being asked as an organization on a daily basis. So I'm going to start with some basic facts about coronavirus, some of which you'll have heard in the press. But in summary, we've known as a scientific community about coronaviruses for a very long time. We know they infect animals widely, and there are some that also infect humans. In fact, there are coronaviruses that are responsible for giving us mild diseases such as the common cold. But there are some coronaviruses that cause significant diseases and significant illness. And amongst those are the severe acute respiratory syndrome, or SARS epidemic, which was in 2002, and more recently the Middle East Respiratory Syndrome, or MERS, which was seen in 2012, and indeed we're still seeing sporadic cases of MERS arise in the Middle East and the Far East. This particular coronavirus is thought to have spread from an animal source to humans, possibly in what's called a wet market in China. But there's some debate about that now. It's possible that in fact it was circulating in the communities earlier than its first identification at that wet market. But it certainly looks very similar to the SARS virus. It's distinct from both SARS-CoV and MERS-CoV, but it has it's closest genetically to SARS, and so it's now been named SARS-CoV-2. And it's the virus responsible for the current illness which is spreading across the globe. We know that its incubation period is between 2 and 14 days, with a median incubation period of about 5 days. So most people will start to develop symptoms 5 or 6 days after being exposed. And we know that most people are most infective when they're symptomatic. There is some evidence that asymptomatic people could be, asymptomatic people could be infectious, but the evidence for that is relatively weak at the moment. It's thought that you'd have to have very close physical contact to someone who was asymptomatic. And so the original concern that asymptomatic carriers were passing the virus on to lots of people seemed to be less grounded than they were. I should stress throughout this presentation that a lot of the data that I'll be presenting is subject to change. So if you're listening to the recorded version of this, it's worth making sure you're listening to the latest webcast recording, but also some of the data that I'm presenting should be viewed in that context. But it's certainly true that most people who get the illness that this virus produces get very mild disease. They'll usually present with a fever, and then they'll develop a cough. Some people will get a mild or severe breathlessness, but as I say, most people get mild disease. About 20% of people who are infected progress to severe disease, and about 5% of those require intensive care. And I'm going to talk more about those estimates later, and also about some work that's been done at Imperial College in London. So here are the numbers. The first cases were reported in Wuhan to the World Health Organization's regional office on the 31st of December last year. And in fact, it shows how rapidly things are changing. I looked at a situation report I wrote in early January saying that China had reported 300 cases. And now globally, we have 218,000 cases in 169 states and countries. But you can see from the numbers, a large number of people have recovered now. The raw data, and I know that the numbers don't quite reflect this, and I'll explain why, but the overall mortality rate is thought to be between 1% and 2%. Now, the reason why the figures on the right don't represent the 1 or 2% that I've put on the left of this slide is because we still really don't understand what the community incidence, what the attack rate of the virus is in communities. What we do at the beginning of a pandemic or an epidemic is we test the most symptomatic patients, because they're the patients that present to their physicians, they're the people that present to hospitals, and so of course they are tested. So you're testing a subset of those that are infected, and so it can give you an inappropriate impression of how many people are infected with the virus. It's highly likely when we do what's called serological testing, we'll find that many more people have been infected with the virus in China, but by far the majority of them had very mild or possibly even asymptomatic disease. It's also true that most people who die from the virus infection tend to be the elderly. And those that have pre-existing heart disease or lung disease. But we still need more data on this. And one of the fallacies, one of the myths that's going around the world is that this disease only affects the elderly. There are certainly instances in children, and there are instances in young people, even though the majority of people will have mild disease. Thankfully, children tend to recover completely or have very, very mild disease. But we'll talk a little bit more about that later on. So in January and February, we saw a rapid increase in the number of cases in China. But I think these graphs, I'm sorry, this isn't a terribly clear graph, but it does tell a story, I hope. So the orange line, which is you see rapidly increasing through January, represents Chinese, an aggregate of the total number of cases reported in China. And as you can see, that's flattened off. The green line below that represents all the patients who have now officially been declared to have made a complete recovery. And the yellow line are cases outside mainland China. And as you can see, they've rapidly increased recently. So until the 26th of February, most new cases were seen in mainland China. And you can see that on the graph on the right, and that's the blue line. But by the end of February, we began to see more cases every day being reported outside China. And since then, we've seen the number of people reported to have recovered in China increase, and the number of cases in mainland China decrease. And in fact, today, officially as of today, for the first time since the beginning of the outbreak, there have been no new suspected cases in Wuhan and Hubei province in China at all. And so it does look, at least at this stage, that what are thought to be quite draconian measures that the Chinese took to control the spread of the virus have been effective in preventing new cases. And again, we'll talk about containment strategies in a minute. And that's just a representation of the percentages. And you can see the orange block now shows that the total number of aggregated cases outside China exceeds the number of cases that have been reported in total inside China. So what are the practical phases of the outbreak? So there's always a pre-pandemic period, when a virus is a new virus, often a novel virus, is identified as being a possible candidate for producing a pandemic. We see new viruses arise fairly frequently, and actually few of them become established in the human populations. But in this case, of course, we're well past the pre-pandemic phase. Then you have an importation phase where travelers from the area of the initial outbreak, the initial epicenter, travel around the world and then present as being unwell, and you'll see individual sporadic cases in countries around the world and some local spread, usually in family members or close contacts. Next, there's a cluster phase where if you don't contact trace those people aggressively and isolate their contacts, you get larger outbreaks. And we, as recently as 3 weeks ago, we were considering that Italy, Iran, South Korea, and Japan were in the cluster phase. But of course, things have moved on a lot since then, and essentially those countries have shown established community spread, as have most European countries now, and we're seeing, of course, that in the US as well. And then lastly, a pandemic phase where there's established sustained community spread in 2 or more WHO regions. And that's the trigger usually, although it's not clearly defined, that's usually the trigger for WHO for declaring a pandemic. Now, it's interesting that the WHO are very clear that countries should be still identifying cases, contact tracing and isolating, because that's, for various reasons, that's one of the best ways of reducing the total amount of the total spread across a community. But let's just go through each phase and see what countries do. In the importation phase, it should be possible for countries to contain the spread. And so that's the containment strategy. Early identification of cases, contact tracing of anyone they've been in contact with for the previous 2 days, and isolation of everybody that tests positive or has symptoms suggesting they might have the illness. In the cluster phase, the WHO have always advocated stepping up containment strategies, so to try and reduce the spread, but eventually in certain health areas the health capacity is outstripped and it becomes difficult to test everybody, and that's what we saw in Italy. Those outbreaks are being controlled, but not everybody is being tested, and in fact in the UK we have a situation now where we're not community testing patients at the moment because we don't have the resources to test everybody that might be carrying the virus. Then there's community spread, where there's spread, but in public spaces and where it's not related to a single outbreak. And then again, the WHO are advocating continuation of the containment strategies, but lots of health systems and governments are advocating a delay strategy. Now, the delay strategy accepts that lots of members of the population will become infected with the virus, but seeks to delay the transmission through the community and therefore spread out the burden on the healthcare services so that more people can receive effective care. And the pandemic phase, I suppose, is slightly different from widespread community spread in that it's occurring across the world. And it's important to remember that the phase of the pandemic will be different across the world. In fact, China, of course, is just coming out of the first phase of their pandemic, where they're reporting no new cases, whilst at the other end of the spectrum, the United States are lagging slightly behind Europe. As a concept, it's important that companies try and mirror the approach of their local authorities, and the advice they give to their staff and the processes they put in place are aligned with the local healthcare advice so that they maintain credibility with their staff. So I just want to talk a little bit about some of the data that's come out of the Imperial College study in London, really because it's quite a good example of how good public health science can influence government response. This chart shows who is most at risk from infection. The fatality ratio, the percentage of people who will eventually die as a result of infection, you can see is very, very small in young people. And this data is based on assumptions about the total number of people who are likely to have been infected in a community. So as you can see, really right the way up until the age of 50s, people in their 50s, the fatality rate is really very low. But for the more elderly age groups, the fatality ratios can go up to about 9%. And so it's those people who are elderly and people who have pre-existing disease, particularly if it's cardiac disease, heart disease, or lung disease, or patients who are immunosuppressed. So, for example, they have disease processes where they're being treated with immunosuppressants or they're on chemotherapy. They're the people that the response to the virus, they're the people that we're trying to protect. Of course, clearly, because we want to reduce the number of people that die from the infection, but also because we want to try and avoid overwhelming our healthcare systems, because the secondary effect of the virus and the increased burden is that people will tend to also die from other illnesses and other problems that they would normally, in normal times, be treated for readily. The problem in most Western, in fact, most healthcare systems now, is that we don't run our healthcare systems with very much additional capacity. Most of our intensive care units run at between 85 and 95% capacity at any one time. So there aren't many additional beds or staff that we can rapidly bring online. And that's the challenge. This is a table, again, from the Imperial College modelling. And I stress the models they've used are based on emerging data. There are quite a lot of assumptions in there, and these may change. But this graph is the one that changed the UK's direction of travel in terms of the public health policies. The black line at the top, you can see on the left-hand side, it shows the number of critical care beds that would be occupied at any one time during the pandemic per 100,000 of population. And there's a timescale along the bottom. The red line shows the surge critical care bed capacity. So that's the number of critical care beds per 100,000 of population that a healthcare system can bring online at its most stressed. And as you can see, if we did nothing, which is the black curve, we would vastly, and these are UK data, but the principles apply across the world, we'd vastly outstrip the capacity of our health service to provide critical care for those people who needed it. And then the other lines represent the effects of various social interventions. So the green line shows what the effect is of closing schools and universities. The orange line shows case isolation impact. And then so on until you get the blue line, which shows multiple interventions of case isolation, home quarantine, social distancing of the over 70s. And you can see we're bringing the curve down closer to that red line, where we will be able to cope with the number of additional intensive care patients. But as you can see, these interventions on this graph aren't enough to really protect ourselves. We'd still be, our healthcare systems would still be overloaded by an order of magnitude more than their capacity. However, there's a new, the new word that's being used, or the new technique that's being used to control the virus or to prepare ourselves for the virus is suppression. And the idea of a policy of suppression is that you try and reduce the transmissibility of the virus in the population to the point at which it dies out, until the virus dies out. So you need to make sure that for every infected person, or you need to try and ensure that for every infected person, they infect less than one person during their illness. And when you get down, it's called an R0, when you get down to that level of transmissibility, the virus is not sustainable in communities and will disappear. But you need to take quite dramatic actions at a societal level to make that happen. So here's a graph which shows a timescale along the bottom, and again the number of critical care beds as the other axis. And you can see the do-nothing curve, which is the black line, which we've seen before. And then you have the more severe interventions, which we're beginning to see in the UK and elsewhere around Europe. Case isolation, household quarantines, social distancing, and that involves closure of mass events, sporting closures, closure of public transport networks, school and university closures, aggressive case isolation, either at home or in hospitals, and all of the other interventions, including border closures, that you're beginning to see around Europe and are likely to see more and more in the US. When you model that effect, you can see that the green line is below or on the critical care surge capacity, and that gives us hope that with all of these interventions we will be able to appropriately look after those people that need ventilation or other critical care in our hospitals. Now, what's interesting about this graph is on the right, you can see a sudden surge in cases, that green line, in mid-October or November. And what the team did is they modeled what would happen if you suddenly removed those social controls on the resurgence of the virus. Because, of course, the larger the number of people who don't get the virus means that there's a pool of people that can become reinfected at a later date. And so the concern about this sort of intervention is that at some stage this virus will occur as you remove the social controls. And one of the problems and one of the discussions in the UK is about timing, because what you want to do is you want to make sure that people don't get fatigued by social isolation, working from home, having the children at home, not having schools open, and just break the rules and go back to their normal lives. And you result in this rebound case volume. So one thing that's been suggested is that and of course, sorry to add, what we're trying to do here is get to the mass population vaccination campaign, and therefore you can largely mitigate this second event. However, the first thing is that the vaccines probably aren't going to be available for up to a year, and the second thing is we don't really know the effectiveness of the vaccination. Certainly, seasonal flu vaccines are very variable in their effectiveness. Some years, what's called the payload in the vaccine really doesn't protect you from the majority of circulating flu viruses. So the question about how effective this vaccine will be we're still waiting to see. Although there are candidate vaccines, as you will know, that are in testing phases around the world. So just as a last point, one of the suggestions is that what we might see in the next, over the period of this year, and this is the worst case scenario. I mean, perhaps some of these dates are overly dramatic, but what we may see is a situation where we use triggers such as intensive care bed occupancy to be able to switch on and off our social response. So we will have social distancing, which we're seeing widespread in the UK at the moment, working from home, closure of events, a whole raft of measures. But there will be a point where our intensive care bed occupancy falls to a point where we can relax those measures for a period, albeit that the case rate will begin to increase again. Because clearly the sort of social distancing interventions that we're seeing damage the economy and our way of life. And there should be periods, it's speculated that what we'll do is we'll have periods of recovery where we can return to normal life, although we may need to return to social distancing later. So how has this affected us at IMG? Well, in lots of ways. Clearly, we are responsible for providing care to our members all over the world. We have a proud tradition of doing so, and even in extraordinarily difficult circumstances, and we continue to do so. Interestingly, the number of evacuations we're being asked to perform for patients ill as a result of the viral infection are very low. And in previous pandemics, SARS and MERS and others, this was our experience. We were not often called upon to move patients that were severely unwell as a result of the viral infection. But we are seeing patients ringing, members ringing for advice from around the world. Interestingly, there are a large number of air ambulance providers in our network around the world who are more than capable and willing to move patients with COVID-19. But the issues that we have are really governmental. There are lots of restrictions on the movement of patients. Lots of countries are demanding that patients, before they're moved into the country, have negative COVID-19 testing. And in lots of parts of the world, that just doesn't exist or isn't available, and certainly isn't available for people who are otherwise well. And so some of the issues we've had have been trying to persuade governments and border control agencies to allow us to move patients into their countries for higher levels of care without COVID-19 testing, even in the absence of symptoms. In fact, what we're finding is that is possible to do. But it's very labour intensive, requires quite high level contacts in the government, and also often quite a lot of help from our provider networks who are actually operating out of these countries. We're seeing quite a lot of our corporate clients needing to transfer transfer their staff or their volunteers back into the US and back into Europe. They're well, but they're often requiring a degree of logistical support and advice from us because, again, some of those inbound travellers are finding it difficult to find flights because of the number of airlines that are restricting their flight schedules, and also are being challenged by the requirements on arrival. So, for example, self-isolation or other declarations that are becoming increasingly complex. And one of the problems, of course, is that it's a constantly moving goalpost because countries change their regulations and requirements almost on a daily basis sometimes. I touched on local COVID-19 testing. We're trying to keep surveillance not only on our provider networks, so for our air ambulance providers, our ground transport providers and our hospitals, but also on the availability of COVID-19 testing, even in quite remote and hazardous environments. Of course, we're seeing, understandably, fairly high volumes of calls from people who are worried, but well. And our philosophy in lots of cases is that they should stay in country if they're traveling, make sure they have supplies of food and medication where necessary. And we are assisting people where we can to get out of country, but often this is not possible at the moment. So they're often advised to stay where they are. And of course, I touched on this large group repatriations, transfer of staff. Now, luckily, and there is good news, actually, and I'll touch on some of that in a minute, luckily, there are some very simple things you can do to protect yourself. And I make no apology for reiterating the World Health Organization and the CDC's advice, two agencies that are spearheading the world's response to this, which is that hand washing is the single most important thing you can do. People should hand wash thoroughly. In the UK, I think in quite a lot of places now, we're singing happy birthday twice to give us a measure of how long we should be hand washing each time. And the WHO and CDC have produced some very good infographics showing people how to hand wash properly. Not quite as effective, but certainly a very good alternative to hand washing, where hand washing isn't available, is the use of alcohol-based hand sanitizers with 60% alcohol. That has resulted in people panic buying hand sanitizers, and of course the price of hand sanitizers going up. But we're seeing companies increase their production hugely, and I suspect we'll see that hand sanitizers start to come back on the market shortly. Clearly, avoiding proximity to obviously symptomatic people is important. And cough etiquette is very important. If you're coughing or sneezing, you should cover your cough by sneezing into your elbow or sneezing into tissues. If you do have to sneeze into your hands, you should wash your hands straight away or use alcohol. And not be ashamed of keeping your distance from people who are coughing. And again, if you're coughing, to maintain your distance from others. Avoiding areas where people congregate. There's a scientific debate going on about the effectiveness of this. Lots of countries are stopping public gatherings, such as sporting events. How much of an impact that makes on the spread of the virus is somewhat questionable. But again, when traveling, you will probably be expected to socially distance yourself from other travelers if possible. Mask use I want to talk about because, again, it's controversial. In the Far East, it's socially acceptable to wear masks, even in non-pandemic times. You'll see people in the streets in Southeast Asia and the Far East wearing masks. And so if you're an expatriate in these areas, not wearing a mask, you may be criticized for not wearing a mask. The CDC and WHO are making it clear that mask use does little to protect you as the wearer from contracting the virus. I'll say that again. If you are well and you are wearing a mask to try and prevent yourself getting infected, its use is minimal and probably isn't protective. In fact, it may make things worse because it may give you a false sense of protection and security. However, both WHO and CDC are saying that if you are caring for someone if you're a carer, either at home or in a hospital environment, and you're caring for someone with COVID-19, then you wearing a mask and your patient wearing a mask does reduce the risk of infection. So there's been a scarcity of masks across the world, and it's important that we don't buy masks for personal use, and they should be available for healthcare professionals. So again, how do companies protect themselves? They really mirror all of the approaches that their health authorities are putting in place locally. Encouraging social distancing, making sure staff can telework wherever possible, and spreading people out geographically in the office, avoiding them congregating in traditional areas like break rooms and cafes and canteens. Cancelling non-essential face-to-face meetings. And where people have to work together, for example, in contact centres, you discourage staff from visiting each other's work areas, sharing handsets, for example. And if they do, make sure they wipe down their work areas, their keyboards and their headsets with disinfectant wipes after that person has visited their area. Alcohol gel needs to be widely available and accessible. People don't tend to walk the length of an office to get to some. It should be widely and easily available. And cough etiquette should be taught to staff as well. Thorough hand washing, of course, should be encouraged. And really, very importantly, staff must be told that if they are unwell, then they should stay at home. As I say, most people have mild disease, but they will become symptomatic, so they'll cough and sneeze, and you want to try and avoid those people from spreading the virus around the office space because they feel they have to come to work. And lastly, tracking the incidence of illness is important in an organisation, depending on the pandemic phase. It's important to know who's had the illness, whether they've been tested. And of course, increasingly, people won't be tested because there'll be a large number of people infected and the availability of testing will reduce. But certainly knowing who has had symptoms of COVID-19 and is likely to have had the disease is important because it's felt likely that having had it once, you won't contract it again. Although that doesn't mean you won't get a similar disease if it does recur next year, but you almost certainly won't get it this time round. So lastly, and briefly, IMG, of course, are prepared for the consequences of this virus, both in terms of maintaining our services internally and also understanding the position of our clients around the world and how we can continue to provide services to those members through our provider networks. We have a central coordinating coronavirus response team, which is comprised of people who are involved in operational delivery, physicians, nurses, and senior executives. And they're responsible for making sure that all areas of our business are planned for and can continue to function. We're well prepared to protect our staff internally. We have a widespread implementation of personal protection measures across all of our sites and a program of making sure that the majority of our staff can work remotely. We keep constant surveillance on our air ambulance network and updated on their capability to move COVID-19 patients and other patients, as well as understanding their local environments and what their governments and healthcare agencies are telling them to do. And we've reached out to our largest groups and understand where their members are and potentially the challenges that they're going to face around the world. And lastly, and certainly not least, we have refreshed our relationships with significant government bodies, particularly the State Department and other agencies in the US and US governmental contacts within the public health authorities and also the Foreign Office. And that's so that if we need to have very high-level discussions about moving particularly very ill patients back into the UK or US or elsewhere, we have those contacts established and we can make sure that we have those discussions early. So I'm sorry if that was a little rushed. There's a lot there, I know. I hope it's been of interest and helpful. Again, be aware that a lot of the conclusions and the numbers that I presented are subject to change, so we'll be repeating this webinar fairly frequently. But in the interim, I'm quite happy to take any questions.
Great. Thank you very much, Dr. Tothill. Again, just want to state we will answer as many questions today as time permits. And any questions that you submitted either through the registration process or in the Q&A as we've been speaking, if we are not able to answer them directly, we will follow up with you by email. So now let's dive right into our first question. Dr. Tothill, what is the typical progression of symptoms with COVID-19, and at what point is it evident that someone may have severe disease requiring hospitalization?
Yeah, that's a very good question. Again, I can't stress enough that most people have mild disease. Most people, and you know, so it's the usual bell curve. Some people will present with quite unusual symptoms, but the majority of people will tend to present at the very beginning with a fever. And they'll get a bit achy, maybe a little muscle pain, but it'll feel a bit like the flu at the beginning. The next symptom that most people develop is a cough. It's usually a dry cough. You don't tend to get upper respiratory tract symptoms like you know, a runny nose, or some people have a sore throat, but it's usually quite a dry presentation. So it's a dry cough and a fever. And then a smaller percentage of patients will start to get breathless. Breathlessness is a sign that you need to seek further medical help. Most people with COVID-19 will be able to self-quarantine at home, be cared for by others in the house, albeit with some care about infection, and then get better very quickly. But patients who become breathless need to seek further help. And about 20% of patients, people that contract the virus, will need to go to hospital and require some supplemental oxygen therapy. But again, by far the majority of people who are admitted will get better.
Great. Another question here, what medications are recommended to control those symptoms for those who do not have severe disease but do feel quite unwell?
Yeah, so the important things are to really treat yourself a little bit like you'd had the flu. So, you know, resting, fluids. There's been a bit of controversy recently, or well, I say controversy, there's been some questions raised about the use of ibuprofen, so non-steroidal medication in treating the pyrexia, the fever. It's not clear, really, whether there's any basis for concern about using ibuprofen, but certainly in the UK, following a sort of social media discussion about this, the UK public health authorities have suggested that just to be safe, people are advised to use paracetamol. Essentially for treating their symptoms, not non-steroidals like ibuprofen. But again, we really don't understand whether that's a real thing, and it has to be taken in the context of no real hard scientific evidence that it makes the symptoms worse.
Okay, great. One question that just came in: how long does the COVID-19 virus stay in the air and on surfaces?
That's a really good question. So we think that the method of spread of the virus is almost certainly mostly through coughing. The droplets that spread it are thought to be quite large. It's not aerosolized like, so for example, flu viruses. So sneezing is probably less important than coughing and spreading it, but the virus certainly will live on hard surfaces. There are lots of opinions about how long that virus can survive on hard surfaces and how long it's viable for. So I'm not going to say whether it's an hour or 2 days, or an hour or 2 days, or you know, put a number on it. But it certainly does survive on hard surfaces. Some of the factors that influence that are the humidity of the air temperature, the surface, the type of surface, and non-porous surfaces, so hard surfaces, tend to keep the virus alive longer than soft furnishings. So, for example, you're more at risk if you're touching desks or other hard surfaces. What I will say is most domestic cleaners kill the virus immediately. So cleaning down surfaces regularly, and again, as a corporate approach to this, employees should be told to clean down their entire work areas, their keyboards, mice, phones. When they arrive, if anyone visits their work area, and at the end of the day, religiously, because yes, you could certainly in a working day acquire the virus from a hard surface around the office. Whether it's viable at a day later, that's another question, and probably not. But we just don't know yet.
A related question that just came through, do we know how long the virus will stay in the air? And one example that was provided is getting into an elevator with somebody who may have coughed in that elevator previously.
No, I think there's little evidence that it hangs suspended in the air. These are large droplets. They don't travel very far, and they don't hang sort of what we call aerosolization. They're not attached to very tiny particles that float around in the air. So you need to be close to someone who's actually coughing in your vicinity to acquire this. You won't acquire it by walking through an area where someone's coughed in that space sort of 10 or 15 minutes before.
Okay, great. One question that just came in, just to clarify a previous statement that you made, Dr. Tothill, you mentioned paracetamol as the standard in the UK. What are the brands that would be more recognizable of that particular medication?
So acetaminophen is, okay. Yeah. So acetaminophen is paracetamol in the States, and okay. And ibuprofen is Advil.
Great. Another question, can you get reinfected after you've had the virus already? Do we know this?
So that's a very good question. Most the opinions are that at the moment, if you have the illness, if you've got COVID-19 and been infected, that you can't get infected with that virus again. There are always exceptions. We do see occasional cases where people appear to be reinfected. We think that, and it will depend on how vigorous the immune response we mount is, and we won't really know that until we see this serological testing, which is being done in China at the moment and elsewhere. But in general, if you've been infected with COVID-19 or the virus, SARS-CoV-2, then you won't get that illness again. The thing is about it, though, the slight caveat is that there is always a sort of genetic shift in a virus. It can change its genetic makeup and make itself slightly less vulnerable to your immune defenses. So you won't get this exact virus. You may be reinfected at a later date with a variant of this. And that's what sort of happens in seasonal flu. You can get flu in 1 year and then have a different type of flu the next year, because although you're immune to the virus that you caught this year, the one next year will look slightly different. We don't really know with this virus whether that will happen. We don't even really know whether it's likely to recur on a seasonal basis, i.e. stay in our communities and recur each year. So it's difficult to tell whether immunity this year will protect us next year. But certainly there is this concept of herd immunity. And our presumption at the moment is that once you've had the infection once, you won't get it again, at least this year.
Great. What is your estimate, understanding that there's a lot unknown right now, on how long we will be facing these strict travel restrictions due to COVID-19?
Well, that's really interesting, and I think probably I'm going to pop you back to this slide. This is a slide which I think tells the story best, and I think, but this is a presumptive model. If this turns out to be the case, or rather perhaps rather better, if we see this sort of approach, we may see periods for a couple of years where periodically we're unable to travel, and periodically we have social controls in our areas. And that's going to be challenging for the world because, and this is speculative, so forgive me, but it is possible that we'll see different interventions in different parts of the world at different times. And that means that traveling, for example, from the UK to the US or the US to Asia Pacific may be influenced by a whole range of interventions, both at home and abroad, and in terms of the airline capacity to travel. So it's a very much a fluid picture, and it will depend on what approaches the world and individual countries take to controlling the virus. But if we have triggered suppression, which is the model that I've got on the screen at the moment, then we may well see different interventions at different times in different countries. Sorry, that is not a great answer to your question, because it would be super to give you a number. But at the moment, I don't think there is a defined time frame.
Understood. Thank you. Earlier in the presentation, you showed a graphic showing the statistics by age band. And there have been a couple questions around young children specifically, and what parents can do to protect their children from catching the virus.
Yeah, so it's another great question. And I'm hesitating slightly because the data in children is not clear. So it's not clear because there is the possibility that what we are seeing in children, because schools have been closed actually in lots of parts of the world, including China, we might be seeing low incidence and low pathogenicity, i.e., mild disease in children because schools are closed early, and we're not seeing the incidence of the disease. Having said that, there does certainly seem to be something about this virus which means that children get very, very mild disease. And I've just been in a WHO conference actually this morning, and it sort of suggests that quite a lot of children will catch this disease and have completely asymptomatic disease, although that's not confirmed yet. So we can protect our children to a point if we are in a house. So say, for example, a member of the household becomes infected and symptomatic, then you can do sensible things like that person remaining in a room, self-isolating in a room of the house, one of the other adult members of the house looking after that person. But, there is a high likelihood, sadly, that other members of the family will become infected. There are no specific things you can do over and above hand washing and social isolation for children that you're not also doing for adults. But I think people should be reassured at the moment that the evidence is that if children do get it, they will get a mild disease. And also there's some suggestion, again, I'm sorry to be woolly about this, but there's some suggestion that children are less likely to pass the virus on to adults. And it's not known why. It's possible and probable that that's because they're just not symptomatic. So they're not coughing the virus into the environment like adults do. Again, just good hand washing, alcohol gel, social distancing, and common sense when you're looking after someone who is infected.
Great, thank you. The next question here, do we know how long the virus stays in your system after you've become infected?
So again, interesting question. Varying. So let me just go back to how do we test for it. So we test for the virus by, if indeed you are tested, if you're tested, you're tested by usually a throat swab and a test called PCR, polymerase chain reaction, where we're looking for the genetic makeup in our test and we're identifying that the virus is present in the throat. There are always false positive and false negatives. There is some suggestion that once you have the infection for 14 days, you can detect the virus in the back of the throat of an individual. It's unclear about how infective that person is, but again, once they're asymptomatic, the infectivity falls quite dramatically. In terms of how long does it stay in your system, it's certainly not detectable usually after 14 days, although there are occasional cases where you can swab people's throats and still find it. But in terms of it being pathogenic, i.e. causing disease, it's usually only up to 14 days.
Okay, so the next question here, it seems like mask wearing is a bit of a controversy currently. So this question is, if I am physically healthy, should I be wearing a mask to avoid COVID-19?
I think that's again, great question. I think that it's a multifaceted question. I think it does depend on where you live in the world. For a while in my career, I lived and worked in Hong Kong, and it's extremely common to wear masks when you're in Southeast Asia, on the MTR, on the underground, on public transport systems. People often wear them even when there's no epidemic. So I would say that in some environments, your local teams and your friends will be wearing masks, and you should follow suit if you have them available. They are not thought to provide protection for you as the wearer. So I would say that in almost all other environments, mask use is ineffective, and certainly in the current climate, we should be reserving our mask use for people in healthcare environments. If you're caring for someone at home, the current advice is that both the person with COVID-19 and their immediate carer should wear masks. And there'll always be some advice as to how to correctly put them on, how to use them, and when to change them. It should be remembered that the normal surgical masks in a surgical environment in hospital are regularly changed. to maintain their efficiency. And it does rely on both the patient and the caregiver wearing the mask. So the short answer is, if you're well and you're in a city where it's not culturally usual to wear them, there's no need to wear them.
Great, thank you. Switching topics a bit here, how is IMG and the travel insurance industry just as a whole balancing the safety of its employees and suppliers with the contractual and ethical duty to assist customers during this very turbulent time?
It's a very interesting question, and I've been heartened, actually. So one of the other conferences I was on this morning was with a large group of European assistance providers, because it's in our time zone at the moment. And I was heartened by the collaboration that companies are showing each other, and the genuine concern of those companies, of everybody in the assistance industry, for the welfare of their members and their clients, their travelers. So I've been heartened by that outpouring of assistance to each other as a community. So that's the first thing. This is, to turn to your primary question, this is our job. This is what we and I have to say, we love to do. We wouldn't wish these situations on anyone, but providing assistance to members around the world is what our nurses, our doctors, our operations teams, our logistical experts, our security guys, this is what we do every day. And so we're not going to stop doing it, even if it's very challenging. Primary and central to this is having a really robust internal plan that protects our own staff. If our staff get sick and we're not answering the phones and we're not keeping up to date with our providers, that would be it would make it very difficult for us to help our members. So we have a very robust internal plan. We are very flexible, and we communicate regularly with our staff. And I've been delighted to see across all of our worldwide locations how well our staff are adapting to this. So we are here providing services as we always have done, in slightly different ways perhaps, but we're still providing the same services. Externally, we've been delighted with the solidarity that's been shown by our provider networks. They've been responding rapidly to our requests for information. They've been open with communication with us of what they can and can't do. And despite the fact that often they're working 24 hours a day as well, they've been getting back to us with status updates and information on our requests within hours rather than days. So I think across the whole industry, there isn't a conflict really between protecting our staff and providing care for our members. They're aligned. Those two things are aligned. And because we're doing one, we're able to do the other.
Great. Thank you so much. So there are a couple of questions around our ability to do medical evacuations. And we mentioned earlier in the presentation that really our ability to perform them will largely be because of government restrictions. Are we seeing currently any ability to do movements for countries that may have confirmed cases but haven't actually closed their borders yet?
Yes, we can, and actually, so let me just let's go back a bit, one step from that. During the SARS and avian flu outbreaks, one of the experience of the assistance industry worldwide was that patients fell into two distinct categories. Well, three really. Patients who had non-viral related illnesses, and this was also true during Ebola as well. We often see patients who don't have any viral illness at all, but they've broken a leg, no viral illness at all, but they have, cardiac disease, heart disease, for example. And in those cases, we would make every effort to negotiate with a receiving country and a receiving hospital to transfer those patients. At the moment, the limiting factor is not air ambulance ability to move patients. The air ambulance companies are available, they're operating, they're happy to move patients even in and out of high-risk COVID-19 locations. And they have, because this virus is relatively easy to protect yourself from. The limiting factor is often the port authorities and the health authorities accepting patients without COVID-19 testing. But that's a matter of us trying to do intensive negotiations. And hearteningly perhaps, the sicker the patient is, the easier we find it to get consent to move patients. And certainly that was our experience in the avian flu outbreaks and in Ebola cases. We used lots of different techniques for moving patients, but we usually got quite positive responses from governments when we tried to do so. Now, we're in a state of a pandemic at the moment, which is problematic, because countries need time to settle and to adjust their approach to border controls, because at the moment countries are much more interested in the large number of people that are flying into their countries on commercial flights than they are the small numbers of patients that we're bringing in on air ambulances. But as that situation stabilizes, we can have much more constructive discussions with individual countries and individual health authorities. But at the moment, as I say, we're in a phase at the moment where a lot of knee-jerk reactions are happening across the world to border control, and it makes those discussions very hard. Does that help?
Yes, no, absolutely. Understood. We've had a couple questions, Dr. Tothill, around quarantine and what that means. When, for example, if you return from a trip, whether it's abroad or local, and are mandated to self-quarantine, what are those rules? And in particular, if you live in a large household with children and with other family members, is it required to separate in a room, or simply to stay within your home?
So in fact, this is where we're seeing a lot of variation of advice across the world. On the whole, certainly what seems to be coming out of most health authorities at the moment is that if you are simply self-quarantining because you have returned from a place where there are a large number of cases, then you don't need to be to stay in a single room, and have your food passed through the door by one member of the family. You can continue to mix with the family. What you should do in that environment, though, is enforce strict hand washing protocols, use alcohol if you have alcohol, and also be observant for anyone else in the family developing symptoms. Remember, it is possible that you might get a mild illness from this, but someone else in the family, particularly if they're vulnerable, might get a severe illness. So it's important that you think about the environment you're in. And in fact, CDC have some very good guidelines on, I won't they're too detailed to go through in depth here, but they've got some very good guidelines about quarantining and self-isolating at home. They're aimed at health professionals, but they're a guide which allows a health professional to make an assessment of whether it's safe for someone to be treated for COVID-19 at home. But there are two distinct situations here. There's returning asymptomatic from a high-risk area, and then there's actually having an illness. If you have an illness, you are advised to try and stay in one room, not mix with the family, hand wash regularly, as should the rest of the family, and maintain social distancing from the family around you, apart from one caregiver. But that's a different situation from just coming back from a high-risk area. I should point out that as the pandemic spreads and large numbers of people in the community acquire the virus, then the distinction between someone returning from, say, France to the US, if that were possible, which of course it's not at the moment, but someone returning to the US from a high-risk area and your local environment may be very little different. So in the next phase of this pandemic, I suspect we will find that health authorities drop the requirement for isolation on return from travel. I don't think we're there yet, but obviously there's little point in isolating yourself if the incidence of the disease around you in your community is just the same as the community you've just left in, say, Italy.
Okay, wonderful. And I think we have time for one final question. And that is, there is talk of the virus being temperature sensitive, meaning that once the summer months hit, the virus will naturally go away. Is there truth in that?
I was so hoping that we could end the webinar with a question that I could give you a definitive answer. It is known that with seasonal flu, that the incidence decreases as the temperature goes up. That has been the assumption in this outbreak, but the truth is that the virologists I've spoken to recently tell me that there is no definitive evidence for this particular virus that is the case. It is the hope rather than the case. And so we will have to see. It's certainly warmer temperatures are in our arsenal of things that we hope will fight the virus, often for social reasons as well. But I'm afraid the jury's out on that.
Understood. Well, Dr. Tothill, on behalf of all of us joining today, thank you so much for your time. This has been incredibly informative. This does conclude today's webinar. And again, the session will be available on demand afterwards. We do welcome you also to visit our website for the latest information on COVID-19. And we will be sharing details on future webinars as this topic continues to evolve on a daily basis. Thank you again, everyone, for joining us today.